Good afternoon, Dr. Soumya and Dr. Seema. Can we start?
Yeah, sure. From my side, sure.
Okay. The first presenter for this session is Dr. Kamya, free paper 1303. Kamya, are you ready?
Yes, ma'am. Good afternoon, all. I'm presenting my paper on the approach of undergraduate students.
Dr. Kamya, log in through only one device because there is a lot of echoing.
Hello.
Yeah, now you're audible.
Okay, ma'am. Good afternoon, all. I'm presenting my paper on the approach of undergraduate students towards promotion of eye donation, a narrative analysis of the eye donation awareness campaign, teaching through learning and learning through teaching. Corneal blindness is of global concern and fourth common cause for blindness, according to WHO. The demand for cornea far exceeds the number of eye donations. National Eye Donation Fortnight is observed annually from 25th August to 8th September with an aim to create awareness about eye donation and to promote individuals to pledge their eyes. What we do in our institute, various competitions are held for the undergraduate students as part of Eye Donation Fortnight annually. It is done with an aim to create awareness in the public and stimulate sensitivity among students. What we did, we explored and analyzed student participation from the attitude, ethics, communication, and medical education perspective. Narrative analysis was done of the approach of students and content of submissions. 44 student submissions from eye donation fortnight. The analysis showed that 90% of the students used the slogan approach. Don't just leave a vision. Such short, striking, and memorable phrases were used by students in their presentations. Motivation push contributed to 65%. Give someone your eyes to bring color to their lives. Such stimulating and inspiring statements were put forward by students in their submissions. Such approaches, the students learn to merge knowledge and expression to be impactful. Can we light up others' darkness after we die? This is one of the examples of the altruistic approach brought by the students in their posters. Useless to the dead, priceless to the blind. Eyes never die. These are few examples of the emotional eloquence seen in 20% of their submissions. Through these approaches, the students learn to unify into healthcare the patient's perspectives and value systems. The only way you can live after death is sharing your vision. The spirituality slant contributed to 10% of their poster submissions. The dissipation of myth approach considered the myths with regards to eye donation. Through these approaches, the students learn to integrate in healthcare the cultural, religious perspectives of patient community. The methods of presentation used by them were poetry, which indicates creativity, quoting a few lines, blink once, blink twice, the beautiful eyes that once saw the world is now giving her the gift of a lifetime. That beautiful eyes of theirs is surely leaving their kind soul behind in the world with her. The artistic angles were in the form of digital art, t-shirt painting, and sketches. Through these presentations, the students learned to make an impact by blending creativity, expression, and knowledge. Last but not least were the video presentations. The first one shows where one of the medical students meets with a road traffic accident and loses his vision subsequently. After that, he undergoes surgery and regains some amount of vision in his eyes. The second video presentation was where the medical students have themselves conducted interviews with the visually impaired in the district blind center to understand the perspective of the blind life. Thus, by interacting and stepping into the patient's shoes, the students learn empathy and narrative skills. Thus, by all these approaches, it contributes to the attitude and ethics component of the EdCom model. And by poetry, artistic angle, and video presentation, it helps in contributing to the communication component of the EdCom model. EdCom stands for Attitude, Ethics, and Communication. This model was proposed by the Medical Council of India with an endeavor to strike a balance between the 5 identified roles of an Indian medical graduate, which includes clinician, leader and member of healthcare team, communicator, lifelong learner, and professional right from the first year of medical training. In conclusion, participation in competitions in national programs like Eye Donation Fortnight can stimulate holistic and self-directed experiential learning through creativity, emotion, and active engagement. It incorporates the EdCom model. These are my references. Thank you.
It was a nice presentation, Dr. Kamya,
Thank you.
where you have actually shown through your presentation how the students have learned the attitudes and communication and ethics part, which is now a part of AdCom module as proposed by NMC. So it was a good presentation.
Thank you.
Dr. Kamya, nice presentation. I'd like to ask you one question. On what basis did you draw the conclusion that you have mentioned?
Ma'am, I couldn't hear you, ma'am. How?
Okay. So you've said, what was your conclusion and how did you draw that conclusion?
Conclusion was, ma'am,
Were you able to hear me?
EdCom model in medical education as suggested by the Medical Council of India, because we are encouraging the students to take part in such competition and ensuring a holistic education.
Just a thought. So maybe a question prior to all these approaches might be the next way to go ahead, isn't it? That way we can see significance and all know that these approaches have actually helped in learning.
And we just analyze the poster submissions and the various forms of submissions by the students, and that's how we have concluded, ma'am.
Right, nice. I totally agree. Very nice presentation.
Thank you, ma'am.
If there are no more questions, I think the next presenter can start sharing the PowerPoint. That is Smita BT. Is there a connectivity issue? If it is, then I think we can move on to the next presenter till this gets sorted out.
Yes, ma'am. Coming to introduction, myopic eyes have an enlarged optic disc with a large cupped ratio and the larger area of the peripapillary atrophy and localized retinal nerve fiber they are depicted. Myopia has been identified as an independent and a strong risk factor for primary open-angle glaucoma. In myopic glaucoma, both myopic changes and the glaucomatous changes changes are thought to be present, which leads to misdiagnosis of glaucoma. So, our aim of this study to use the OCT, which helps to measure the thickness of the layers of the retina and to detect the changes in the RNFL and the ganglion cell inner plexiform layer in myopic individual. Hence, we did this study to determine the effect of the increasing myopia and optic disc area on RNFL layer and ganglion cell inner plexiform thickness profile in healthy individual, which predisposes for the development of glaucoma. Coming to methods, it is a cross-sectional study which was conducted on a healthy myopic individual. 100 eyes of 50 myopic healthy individuals were included. Inclusion criteria being age between 20 to 40 years with best corrected visual acuity of more than or equal to 6 by 12 were included in the study. Exclusion criteria, patient with a degenerative myopia with a glaucoma or ocular hypertension, congenital optic disc defect, ocular anomalies which affect the ganglion cell inner plexiform layer and the retinal nerve fiber layer. Ocular trauma and previous ocular surgeries were excluded. All the participants underwent complete ophthalmic evaluation. Best corrected visual acuity converted to spherical equivalent fundus photograph and OCT was done accordingly. The subjects were grouped as follows. Spherical equivalent. The subjects were divided into M1, M2, and M3. M1 being low equivalent of less than 3 diopters, and the M2 being the myopic group, moderate myopic group, spherical equivalent minus 3 diopters to minus 6 diopters, and high.
Your voice is not clear, Dr. Smita. Your voice is not clear.
Okay, now it's not.
Yeah, now it's audible.
Okay. The optic disc area, which was divided into D1, D2, and the D3. D1, a small disc area, which is less than 2.0 mm square, and D2 with a medium disc area with 2.0 to 2.5, and D3 with a large disc area, which is more than 2.5. According to the result, out of 100 eyes, 52 were men and 48 were women. 37 were included in the M1 group, 39 were in the M2 group, 24 were in the M3 group. In the disc area, has categorized as 59 were included in the D1 group, 34 were included in the D2 group, 7 were included in the D3 group. Average retinal thickness were taken, which shows has the spherical equivalent increased, the average retinal nerve fiber layer thickness decreased. Significant thinning of the retinal nerve fiber layer noted has a degree of the myopia increase in all the quadrants except in the temporal quadrant, which shows an increase in the thickness in the M3 than in M2. Average retinal nerve fiber layer and retinal nerve fiber layer in different quadrants were thicker in the larger disc group as compared to the small disc group. Likewise, the average GC-IPL thickness was compared in the M1, M2, and M3. According to the study, as the spherical equivalent increases, ganglion cell inner plexiform layer become thinner. When the retinal nerve fiber layer thinning was compared with the ganglion cell inner plexiform layer thinning in the myopic group, RNFL thinning was more pronounced when compared to GC-IPL thinning, but both were statistically significant. Ganglion cell layer and inner plexiform layer were not affected by the ganglion change in the optic disc size. Discussion. Early detection of the glaucoma can be made by assessing the RNFL and GC-IPL measurement. According to the Weavell study, showed that RNFL and GC-IPL thickness becomes thinner with the advancing the age. But in our study, aging parameters was minimized by enrolling the only young patient between 20 and 40 years. In accordance with the previous study, our study shows that as the SC increases, there is thinning of the RNFL layer. RNFL thickness showed an increase in the thickness in the M3 group compared to the M2 group in the temporal quadrant due to the dragging of the retina towards the temporal horizon. Hence, the significant RNFL thinning was seen in all the quadrant except in the temporal quadrant. Our study also showed that RNFL was thicker in the larger disc as compared to the smaller disc group. Similarly, GC-IPL thinning in moderate and high myopia and thinning was seen in all the sectors. This is due to the stretching effect from the elongated eye. The average GC-IPL thickness in relation to the optic disc size had no correlation. Thus, change in the optic disc size did not affect the GC-IPL thickness. Coming to the conclusion, in our study, the effect of the myopia is more pronounced on the RNFL layer thinning than GC-IPL thinning. However, the effect of change in the disc area was only seen on the RNFL layer thickness, but not on the GC-IPL thickness. Our results therefore indicate the importance of the careful interpretation of the current OCT maps in the cases of the eye with the varying myopic degree and optic disc areas. Thank you.
Nice presentation, Dr. Smitha. Just want to know, when you're speaking about RNFL thinning, what is the diameter that you looked at? What is the size of the circle that you looked at when you were checking the RNFL thickness? And why is that important? Dr. Smitha? Because usually we're looking at a 3.4 mm squared area, right? How is it significant in a myopia? We can't hear you, Dr. Smitha. Hello? The voice is breaking. I can't hear.
Now, ma'am?
Yeah, better.
Yes, ma'am. In high myopic cases, RNF thinning is seen. So,
Dr. Smitha?
Yes, ma'am.
We couldn't hear what you said till now.
Can't hear me, ma'am.
Voice is breaking.
I was breaking. Yes, ma'am. Now, ma'am?
Yeah.
Yes, ma'am. Hello?
Yeah.
Question, ma'am?
That's what. So when you're checking RNFL thickness, what is the area that you would check for? Because in a normal OCT for any other individual, 3.4 mm square is the area. So is that significant in a myopia? Should you take a larger area is what we're asking.
Yes, ma'am. We actually checked on the superior quadrants. We divided into quadrants, ma'am, and we checked in the superior, temporal, nasal, and inferior quadrants, ma'am.
All right. Because, like you said, because of the retinal thinning itself, there will be spread, in a sense, a spreading of the nerve fiber layer, right?
Yeah,
so, and there could be an erroneous, effect of an RNFL thinning when it's actually not there, just because the retina is thinned out.
Okay.
Or stretched, right?
Sorry, ma'am.
That's it. It could be an erroneous finding. The RNFL thinning could be erroneous just because the retina is stretched. So what would, if you had to do a further study, what would you like to do?
Maybe I'll correlate with the other parameters of axial length and yes, ma'am. Maybe axial length,
Right.
optic disc, and
maybe right, and maybe you can follow these people up and see whether glaucoma actually happens. Yeah.
Hello? Yeah, I've logged in actually. I'm there online. Yeah, I've logged in already. Yeah. Okay. Thank you.
Dr. Nagashri, if there are no more questions, can we move to the next presentation?
Yes,
Dr.
please.
Hello?
Hello, am I audible? Good afternoon.
Yes, you're audible. I think the next presenter was Dr. Nagashri. Anyhow, you can start your presentation, Dr. Fauzia. You already started sharing your screen, so you can proceed.
Good afternoon. My study is a study of profile of low vision patients in the effectiveness of low vision services in Tertiary Eye Institute. Introduction. The number of people with impaired sight that cannot be improved with the use of spectacles and other treatments is growing. Medical intervention is unlikely to reduce significantly the number of people with impaired vision in the foreseeable future because there is currently no treatment for all primary cause of visual impairment. Given that it will not be possible to cure visual impairment, the emphasis must be on providing an effective rehabilitation low vision service. Methodology, a prospective non-interventional descriptive study of 37 patients referred to low vision clinic during the period of January 2021 to September 2021 was conducted at our tertiary eye care hospital at Bengaluru. Patients with OU, best corrected visual acuity more than 618, less than 618 to finger counting at 1 meter and aged more than 8 years were included in the study. Each patient was subjected to a detailed assessment which include patient's demographic data, ocular history, visual acuity recording using logMAR charts for both distant and near vision, refraction, anterior segment examination, fixation test, visual field testing by finger confrontation method, color vision, assessment of contrast sensitivity using hiding ED charts, and patient's requirement for daily activities was recorded. The required power and magnification of low vision device was calculated and accepted device based on the individual requirement was prescribed. The reading improvement with low vision device before and after was recorded using logMAR charts. The results were as follows. Out of 37 patients, 51.4% were males and 48.6% were females, the mean age being 26.22. The best corrected visual acuity in 91.9% of the subjects was more than 3/30 logMAR for distant in the better eye. The color vision, only 21.62% had normal color vision. Fixation, about 59.5% of the patients had central fixation. The rest, 40.5%, had an eccentric fixation. Retinitis pigmentosa was the most common cause of low vision, followed by pathological myopia, rod cone dystrophies, and amblyopias. The other causes were retinochoroidal colobomas, Stargardt's disease, traumatic optic neuropathy, and congenital infantile esotropias. About 33.7% had presenting visual acuity worse than 1.3 logarithm of the minimal angle of resolution at 3 meter in the better eye, and the mean logMAR at a near distance was 2.6 logMAR units. Following low vision aid trial, 73% of the patient had a visual acuity of 1.6 to 1.0 logMAR units. The average baseline improvement in the near vision in right eye was 1.7 logMAR units, and in the left eye was 1.9.
Got it.
This is a significant improvement in the reading ability in patients with low vision aids. Here is a box chart which shows the improvement which is seen in the better looking eye. Dome magnifiers and stand magnifiers were the most preferred low vision devices, followed by handheld magnifier, pocket magnifiers, and bar magnifiers. Discussion. One aspect of a comprehensive low vision services is the provision of suitable low vision aids. These devices help people to read and are likely to be beneficial because the inability to read is the chief complaints of patients with impaired vision. However, even the benefits of low vision aids are poorly recognized. This is not surprising as there has been relatively few studies of the effectiveness of low vision aids. The purpose of this study was to quantify the improvement in reading performance associated with the use of low vision aids. Following use of low aid trial, 73% of the patients had a near visual acuity of 1.6 to 1 logMAR units. The study clearly shows that the low vision services helps people with impaired vision to read. Conclusion, there was a significant improvement in the ability to read using low vision services. A thorough visual examination of patients with low vision and understanding their daily requirements is important to provide suitable visual rehabilitation and improvement in quality of life. The references. Thank you.
Yeah, it was a nice presentation, Fauzia. Your age group was mainly young population, right?
No, ma'am. The population was aged more than 8 years.
Yeah,
Up to
young.
yes, ma'am. Yeah. It was catering the young population. Yes, ma'am.
Yeah, and you have done a. Was there a follow up of this these group of patients?
We did have follow up for a few patients. We could not get back few patients, ma'am. So the follow up was not included in the study. But we are looking forward. We are continuing the study right now. As of now, it's an ongoing study. We are getting few more patients, so we will be following them up.
Okay.
On what basis did you say that the vision improvement is significant?
So
There was an improvement, I agree, but on what basis did you say it was significant?
we actually did a variance, a coefficient of variance we had calculated. So based on that,
Okay.
we got an average.
Which was statistically significant?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay.
I'm audible, Doctor. I'm Dr. Seema here. Am I audible?
Yes, ma'am.
Yeah, Dr. Fauci, on what basis did you usually when we talk of low visual aids, we think of vision poorer than 618. What exactly were you trying to aim at while doing this analysis? It is like patients with pathology, you're giving some improvement.
Yes, ma'am.
We are thinking of something poorer than 618 vision.
Yes, patients who do not have improvement with medical management, either with spectacles or either with patients who have been given guarded visual prognosis to aid their quality of life, this low vision services has been started in a hospital. So it is for patients whose vision can't be improved with traditional treatments, like with either with medical management or surgical management. Those patients are referred to our clinic, to
I
the
would
low
call
vision
them
clinic.
defective vision than low vision, you know. When you talk about low visual aid, we are expecting patients to have poorer vision.
Yes,
I was under that impression, isn't it? 618 is not very poor. On what basis did you classify it as a poor for category into low visual aid actually? Because you title your study as low study profile of low vision patients and effectiveness of low visual aids. 618 doesn't seem to be very poor vision to me.
This was the definition that is being followed. This is the SOP that is being followed for the low
For
vision
your
clinics.
study, is it?
Yes,
For your
ma'am.
study.
Yes,
Okay.
ma'am. In our particular tertiary center, this is the like protocol or SOP that we are following, ma'am.
Okay. Thank you.
Thank you.
Yeah, I think Dr. Namita Bhai, you can start presenting because you have already shared the screen.
Hello.
Yeah,
Hello.
you're audible. Yeah.
Yes.
Can you put it to PowerPoint show?
Yes. Yes, sir. Good afternoon, everyone. I'm Dr. Namita Bhore. I'm presenting a paper on risk factors and clinical profile of mucormycosis during COVID-19 pandemic. Mucormycosis is a potentially lethal angio-invasive fungal infection known as phycomycosis and zygomycosis. It is caused by organism of family Mucorrhaceae, including the genera Mucor, Absidia, Rhizopus. The predisposing factors were diabetes mellitus, corticosteroids, immunosuppressive drugs, immunodeficiencies, hematological stem cell transplantation, solid organ malignancies, iron overload, etc. The increasing incidence of rhinoorbital cerebral mucosis in the setting of COVID-19 in India had become a matter of immediate concern. ROC being a rapidly progressive disease, even a slight delay in the diagnosis or appropriate management can lead to devastating implications on patient survival. However, the outcome can be optimized by early diagnosis, prompt treatment, awareness of symptoms and signs, and high index of suspicion, clinical suspicion, and diagnosis by appropriate modalities and intensive, aggressive, and medical and surgical treatment by a multidisciplinary approach. The objective of our study was to study the risk factors and clinical features in patients of mucormycosis patients. It is a prospective observation cohort study done during the month of May-June 2021. The patients admitted in mucor ward were studied in HTBM Patel Medical College, and institutional clearance was given. The examination of eye included visual acuity by Snellen's chart, ocular examination for lid ptosis, edema, swelling, orbital swelling, proptosis, extraocular movements, conjunctiva for congestion, chemosis, xerosis. Pupillary examination for reflexes were seen, vitreous for inflammation, hemorrhage, or exudates, optic nerve examination for to rule out optic neuritis, papilledema, indentation of posterior segment, or any occlusive diseases like central retinal artery occlusion and central retinal vein occlusion. The results of our study included the total patients were 80, 61 patients male and 19 were female. Mean age group was between 50.64 plus or minus 12.44 years. The occupation being most common being businessman, followed by agriculture. And among the patients, 80 patients which we studied, 75 patients were RT-PCR positive for COVID-19. The risk factors showed that the 74 patients among 80 were known case of diabetes and 10 were known case of hypertension. In our study, as we said, 94 patients were RT-PCR COVID positive. With regards to COVID treatment, majority of the patients, or the 62%, had not received injection remdesivir. And 70% of them were given oral steroid treatment, and IV steroid were also received by 22 patients. All of them in the clinical features had sinus involvement, of which 58% had bilateral sinus involvement, 53 patients had orbital involvement, and bilateral involvement of orbit was seen in 9 patients. In the present study, many ocular morbidity were observed, like complete ptosis. 14 of them had partial ptosis, and 39 patients had ophthalmoplegia, of which 12 patients had partial third nerve palsies, and 16 had complete third nerve involvement, and 8 of them had third, fourth, and seventh nerve involvement. This is one of the clinical features of preoperative and postoperative patient of or mucormycosis post-exenteration, left eye. We see in the clinical features that there was complete visual loss in 6 patients due to central retinal artery occlusion, and 19 patients had optic nerve compression. 62 patients had orbital or facial edema, periocular edema, and facial edema. The mean duration of stay for ROCM was 6.31 days. From the MRI investigation, we found 46 had diffuse involvement of PNS, followed by maxilla and ethmoid sphenoid. Treatment given was FS, functional endoscopic sinus surgery, in 55 patients, and 3 patients had FS plus exenteration. 77 patients had received IV amphotericin B, and oral posaconazole was given for 7 patients, and 73 patients received both oral posaconazole and IV amphotericin B. Retroburbal amphotericin B was given for about 18%. ROCM can occur due to inhalation of fungal spores through the nasal passage or oral cavity in a healthy immunocompetent individual. However, it will not cause immediate or latent effect, as immune system will restrict its spread. However, in immunocompromised patients where there is low polymorphonuclear leukocyte count, it gains access to the nasal cavity, and then to the paranasal sinuses, and then through the inferiorly to the palate, and then into the cavernous sinus, and then orbit, and then finally into brain. It can invade the arterial lamina and give rise to thromboembolism and infarction of the inward tissue. Thus, the consequences of the spread could be orbital cellulitis, orbital epic syndrome, brain abscess, and death. Thus, diabetes we saw was the most common risk factor involved, especially during ketoacidosis. And there are 4 mechanisms for which it could cause, like due to distribution of ion sequestration due to hyperglycation of iron, which alters the defense system, again impairing of the phagocytic function and reducing the efficiency of chemotaxis, and also enhancing fungal survival through ion dissociation from sequestering the proteins. In a study which 74 cases which had diabetes mellitus, which emphasizes that diabetes mellitus is one of the important risk factors, and uncontrolled diabetes is the most common underlying disease associated with mucormycosis in India, and the most common risk factor for all ROCM all over the world is also diabetes mellitus. Again, in the clinical features we saw present. Hello. Present study shows 71% of the cases had edema, facial or orbital.
You need to speed up. Your time is up.
Now, findings of the present study shows 21.42 patient had loss of vision. The cause being we saw that 6 cases had CRAO and then orbital compression. Thus, in this era of COVID-19 pandemic, during that time, it was an urgent need to understand and manage the coexisting second infection like mucormycosis, as it has unprecedented effect on morbidity and mortality, and educate all the patients of the early signs and symptoms who had been undergoing treatment or had undergone the treatment, as early diagnosis and treatment with appropriate and aggressive antifungals and surgical debridement can decrease the vitality of the disease. Thank you.
Dr. Namita.
Yes, ma'am.
Yeah, in your study, how many of the individuals were vaccinated? Did you find the data?
Yes, around 11 patients had first dose been given, because that was around May, and we mostly healthcare professionals were given. This were all first dose. About 11 patients first dose had been given. Second had not been completed in anybody.
Okay, and how many of them had to undergo surgical intervention?
11 cases had 23 cases had FES, and 3 cases had FES plus exenteration.
Okay. And what were the outcome of these patients?
Outcome we couldn't follow up, ma'am, but 3 after exenteration they didn't follow up as such. We were doing regular dressing for the 3 patients, but later on they didn't follow up the patients.
What was the mortality rate? Mortality among these patients?
Mortality was not studied, ma'am. Like we after the treatment, we didn't follow up, ma'am.
Okay, but there were no deaths as long as they were in the hospital, is it?
No.
Okay, all right. And how many retrobulbar amphoterisms did you give?
18 patients were given. We had given 6 doses of retrobulbar.
Per patient, is it?
Namita, hello?
Yes.
Doctor.
Yes.
What are the criteria for you to give retrobulbar amphotericin? That's what you're giving.
Yes, the thing is, we followed here was a patient who had a complete loss of vision, and the patient was not improving after, along the treatment of IV amphotericin and posaconazole. It was a subjective decision of the patient and like doctor and patient. When the patient had all lost the sight about PL negative, we tried.
And how many of them had cerebral involvement? You were talking about sinus and ocular involvement. How many had cerebral involvement?
The 4 to 5 patients had this cerebral involvement.
And what is the prognosis following the cerebral involvement? Did they try or
No, ma'am. We
what is
couldn't
the
try.
outcome? Any idea?
No, we couldn't see. No, ma'am.
Thank you.
Thank you. Yes.
Yes, Dr. Pooja, Dr. Suman, you can start your presentation.
Yes, ma'am. Okay, can you hear me, ma'am?
Yeah, you're
Hello.
visible.
Okay, ma'am, can you hear me? Okay,
Yes.
I'll start, ma'am.
Yeah.
Good afternoon, everyone. I am Dr. Suman Devamani, second year postgraduate studying at Adi Chunchangiry Institute of Medical Sciences, Belur. I have done this paper under the guidance of Dr. Pooja HV, and I am here to present a paper on effects of high myopia on macular thickness and OCT-based study. Myopia is defined as a state of refraction in which parallel rays of light coming from infinity are brought to focus in front of the retina with accommodation at rest. Histopathological studies reveal that there is increasing scleral and retinal thinning with myopia. The optical coherence tomography introduced by Huang et al. Is one of the most widely used equipment to assess the fovea, peripapillary nerve fiber layer, and macular region for various retinal diseases. The modern imaging techniques have made it possible to evaluate the relationship between myopia and retinal thickness. Our aim was to study the effects of high myopia on macular thickness using optical coherence tomography. The study period, excuse me, ma'am, just a second. I'm sorry for the interruption, ma'am, just a second. I'm very sorry, ma'am. Give me a minute, please. Just a second. Just give me a minute.
Dr. Suman, time, I think we can ask the next candidate to present. That is Dr. Nagashri.
Yes, ma'am. I'm sorry about that. Yeah, ma'am.
Yes, ma'am. Yes, ma'am. I am Nagashri, ma'am.
Yeah, you can start presenting if you're ready with your presentation. Start.
Yes, ma'am. Yes, ma'am. Present. Ma'am, sharing, ma'am. 1 second, ma'am. Can I start, ma'am? Hello, ma'am.
Your screen is very visible. Your screen is visible and you're audible. You can proceed.
Yes, ma'am. Thank you, ma'am. Good afternoon, ma'am. Myself, Dr. Nagashri from
Voice is breaking. Dr. Nagashri, your voice is breaking.
College present with the help of a chief author. Hello?
Yeah, now we are audible.
Hello, ma'am. Yes, ma'am. Can I continue, ma'am?
Yes. Yeah, please proceed.
Yes, ma'am. Ma'am, yes, ma'am. Introduction. Rickettsial zoonosis are the infectious caused by the obligate intracellular gram-negative bacteria, which are transmitted by the bite of infected arthropods. Systemic involvement is characterized by the triad of high fever, skin rash, and generalized malaise associated with the headache. Most of the patients with the ocular involvement are asymptomatic with self-limited course and hence may be easily overlooked. Ocular complaints associated are decreased vision, redness, floaters, or scotomas. Ocular findings in rickettsial disease include conjunctivitis, keratitis, anterior uveitis, panuveitis, retinal vascular changes, retinitis, and optic nerve involvement, posterior segment changes being more common. Ocular involvement associated with the rickettsial infection has a self-limited course but can result in persistent visual impairment. Though rickettsial disease is common, there is paucity of the reports of ocular manifestation in rickettsia, thus the study has been undertaken. Materials. It is a retrospective analysis of the 50 patients with the rickettsia disease. All patients with the clinical signs suggestive of the rickettsia disease with wheel Felix test positive titer of more than 1:80 were included in the study. Vision acuity was assessed at the bedside for the bedridden patient and using Snellen stat for ambulatory patient, and pupillary examination was performed. Patients were assessed for ocular alignment and extraocular movements. An anterior segment examination was performed with the help of slit lamp biomicroscopy and dilated fundus examination with slit lamp biomicroscopy and indirect ophthalmoscopy. Statistical analysis was performed with IBM SPSS software version in which qualitative data were represented in the form of frequency and the percentages, and quantitative data were represented using mean and standard deviation. Coming to the results, mean age was 12.5 plus or minus 9 years, ranging from 6 to 48 years. The total number of patients studied was 50, in which 27 were males and 23 were females. Single antigen positivity was found in 16 patients. That is, a single one antigen was found in the sera of a patient, and double antigen group positivity was found in 34 patients. That is, 2 antigens were positive in sera of the patients, in which OX2 being positive for tick typhus, OXK being positive for scrub typhus, and OX19 being positive for spotted fever infections. In our study, we had 37 eyes of 27 patients, that is 54% had ocular manifestation among 50 patients which were studied, in which 17 patients had unilateral manifestation and 10 patients had bilateral manifestation. The most common manifestation was retinitis, which was affected in 7 patients, and next most common was vasculitis and papilledema, affecting 6 patients each. Next more common was macular edema, which affected 4 patients. The next was vasculitis associated with the macular edema, papilledema associated with the 6th cranial nerve palsy, and isolated 6th cranial nerve palsy, and optic neuritis affecting 1 patient each. So this is the diagram depicting the posterior segment manifestation. Diagram A depicting multifocal retinitis, in which whitish, yellowish, whitish infiltrates can be seen, and diagram B depicting neuroretinitis associated with the macular edema, and diagram C depicting the juxtapapillary retinitis, which is also associated with the hemorrhages, and diagram D depicting retinal vasculitis, which is associated with the macular edema. Coming to the discussion, our study showed an ocular involvement of 54%, which was comparable with the 2 other studies, and next most common being retinitis with the 26% and retinal vasculitis with 22%, which was also comparable with the other studies. And next common was cystoid macular edema affecting 11% and unilateral optic disc edema 4%, which was also comparable with the other studies. Coming to the conclusion, rickettsiosis patients can have ocular manifestation with predominant posterior segment involvement during acute phase of the illness, and ocular involvement was more common in the double antigen group. For any patients presenting with fever and rash living in an endemic area, ophthalmic evaluation should be a part of routine checkup during the acute phase of the illness associated with the less frequent ocular symptoms. Thank you, ma'am.
It was a nice presentation, Nagashri.
Thank you, ma'am.
Just one question. What about anterior segment findings? Were there any anterior segment findings?
No, ma'am. We didn't find anterior segment findings, ma'am.
Okay. And you said that these patients were also seen bedside, right?
Yes, ma'am. Yes, ma'am.
How did you?
Yes, ma'am. Few patients who were systemically stable were got here, and a few patients who were not systemically stable were examined bedside, ma'am.
Okay. And you had fundus documentation of all these patients? Because this was a retrospective study, right?
Yes, ma'am. Yes, ma'am.
Nagasri, how many of these patients actually had expressed ocular symptomatology as against the signs that you saw? How
Ma'am?
many of them actually? How many of them actually complain of an ocular problem?
Ma'am, I'm not able to hear, ma'am. Sorry, ma'am.
That's okay. So out of the 54% that actually had ocular signs, how many had ocular symptoms is what I'm asking. So how many expressed an ocular problem?
Answer, Dr. Nagashri. Dr. Nagashri, did you get the question?
Yes, ma'am.
Did you get the question what was asked?
No, ma'am. Second question I didn't get, ma'am. Sorry, ma'am.
How many of the patients presented with an ocular symptom? That was the question.
Symptoms, ma'am. Ma'am, out of 27 patients, only 5 patients had blurring of vision, ma'am. Only 5 patients had symptoms.
Was there any follow-up done?
Yes, ma'am. Hello, ma'am.
Were these patients followed up?
Yes, ma'am. These patients were followed up at 1 month and 2 months, ma'am. At 2 months follow-up, everyone had a good visual prognosis, ma'am, with the 6/9 to 6/12 vision.
All right. Okay. So it kind of tells us that even though they don't have symptoms, they need to.
Yes,
examine
ma'am.
them.
Yes, ma'am. Yes, ma'am. We examined, ma'am. We examined.
Nice. Thank you. Thank you, Dr.
Yeah. Thank you, ma'am. Thank you, ma'am.
Dr. Grishma, are you ready with the presentation?
Yes, ma'am.
Yeah, you can start.
Good afternoon, everyone. I'm here, Dr. Grishma, to present a case report of Koyanagi-Harada disease with posterior scleritis in rheumatoid arthritis. Coming to introduction, Koyanagi-Harada disease presents as bilateral panuveitis associated with poliosis, vitiligo, alopecia, and central nervous system and auditory signs. The disease is divided into 4 consecutive stages, namely prodromic, acute uveitic, convalescent, and chronic stage. Posterior scleritis shows signs such as exudative retinal detachment and multiple pinpoint leakages in fluorescein angiography, similar to those of VKH disease. The autoimmune disease rheumatoid arthritis is most common systemic association of scleritis. Coming to case presentation of 51-year-old female with history of rheumatoid arthritis presented with defective vision with pain in both eyes of 6 months duration. On ocular examination, visual acuity in both eyes was hand movements close to face. Anterior segment examination showed bilateral conjunctival and scleral congestion, scleral thinning with medium to large fresh keratic precipitates, shallow anterior chamber, and normal pupil with early lens opacity. Intraocular pressure was 10 mmHg in the right eye and 11 millimeter mercury in the left eye. Fundus examination showed bilateral optic disc hyperemia, optic disc edema, and multifocal exudative RD in both eyes. This is a picture of anterior segment showing in the right eye, it shows scleral thinning of superior temporal and superior inferior quadrant due to recurrent attacks of scleritis, and B scan shows exudative RD with scleral thickening of 2 mm. Coming to fundus, it shows bilateral optic disc hyperemia with optic disc edema and multifocal exudative RD. On OCT, it shows subretinal septa and subretinal fluid was present in both the eyes and choroidal undulation with diffuse choroidal thickening. Ultrasound B scan shows clinical evidence of bilateral posterior scleritis. Neurological examination revealed bilateral sensorineural deafness and tinnitus. Lab investigation revealed RA factor was positive. She was treated with oral corticosteroids therapy and immunomodulators. 1 month after the therapy, her ocular symptoms resolved and the visual acuity improved to 6/18 from hand movements close to face with resolving panuveitis and posterior scleritis in both eyes. Coming to discussion, the differentiation between Koyanagi-Harada disease and posterior scleritis is achieved through observation of typical ocular findings of unilateral and bilateral granulomatous panuveitis with exudative retinal detachment and neurological or dermatological signs not seen in the typical posterior scleritis. Coming to conclusion, this was an unusual presentation of Koyanagi-Harada disease with posterior scleritis with rheumatoid arthritis comorbidity. Posterior scleritis could be early manifestation of Koyanagi-Harada disease in patients with systemic comorbidities like rheumatoid arthritis. These are my references. Thank you. Thank you.
Dr. Grishma, a very well documented case report. Just one question regarding this case. You said that posterior scleritis was present. Was it ever in the B scan? What finding was seen on the B scan?
Ma'am, scleral thickening was there. One of 2 mm scleral thickening was there with exudative, with retinal detachment.
Okay, what is the sign characteristically seen in posterior scleritis on B scan?
Ma'am, T sign is usually seen, ma'am.
It was not seen in this patient? Was it
this
seen?
Case, no, ma'am, it was not seen.
How was diagnosed? And what immunomodulator?
Ma'am, she was on methotrexate and cyclosporine.
For how long? And methotrexate, what was the dose given?
Ma'am, 7.5 mg on tapering dose, ma'am. We took an endocrinology opinion and methotrexate was started.
Was the rheumatological workup done for this patient?
Yes, ma'am. RA factor was positive. Even CRP was increased and ESR also was increased.
Okay, thank you.
Thank you.
I guess we can go on to the next presentation. I don't have any questions.
Is Dr. Sana there? Sana?
Yes, ma'am.
Can you share your presentation?
Yes, ma'am. Ma'am, can you hear me, ma'am?
Yeah, we can hear you, but your presentation is not in PowerPoint show.
It's not in PowerPoint. Ma'am?
It show. Can we have it in slideshow?
Yeah, ma'am. It is in slideshow, ma'am.
But to us, it doesn't look like in slideshow.
It is in slideshow, ma'am.
Okay, continue.
Can you make out, ma'am?
No, to me, it doesn't look like in slideshow.
Yeah, it's not in slideshow mode, but you continue. No problem.
Good afternoon, ma'am. I'm here to present COVID-19 manifestation study at Tertiary Care Center. My chief author is Dr. Nikita. So to start with introduction, coronavirus aroused public prominence after the outbreak of COVID-19 pandemic. The pathogen causing coronavirus disease is transmitted through infectious respiratory droplets.
Dr. Sana, your slides are not seen. It's
Slides are
frozen
not
in the
seen.
first one. Frozen in the first slide. So you may want to share again.
Okay, ma'am, just hold on. I'm sorry for the inconvenience.
Now it's seen.
Is it okay if I present like this?
Yeah, you continue, please. But continue.
Coronavirus aroused public prominence after the outbreak of COVID-19 pandemic. The pathogen causing coronavirus disease is transmitted through infectious respiratory droplets. Recent evidence suggests that ocular transmission is possible as virus is shown to replicate in conjunctival tissue and conjunctival secretions who have tested positive for RT-PCR, with manifestations ranging from ergusia, anosmia, and respiratory symptoms such as cough, shortness of breath. They also have increased risk of thromboembolic events, including pulmonary embolus. It is an highly infectious, and ophthalmologists are at high risk of infection due to many reasons, including proximity between the patients and doctors during ocular examinations, microaerosols generated by non-contact tonometer. Tears are the potential source of infection, and some of them present with conjunctivitis. This article describes about percentage of cases presenting with various ophthalmic manifestations. Acute red eye being the most common condition, bringing the patients to eye doctors in hospitals. So, objective of the study. Various studies have been identified a wide range of various ocular signs and symptoms in COVID-19 patients. However, the complete profiling of COVID-19 related ocular symptoms and disease are still missing. We aim here to investigate the ocular manifestation of hospitalized COVID-19 patients at a tertiary care medical care center. Materials and methods. The study was conducted at a tertiary care hospital in South India. This is a cross-sectional study that was conducted in mild to moderate COVID-19 positive patients. Patients with fever, upper respiratory tract.
When is your presentation tomorrow?
Or asymptomatic individuals who were confirmed positive by RT-PCR from nasopharyngeal swab admitted to COVID ward were included. A total of 263 patients were studied. Information was collected on demographic characteristics, exposure history, ocular and symptomatic symptoms from questionnaires and torchlight examination done taking necessary precautions. So results were so in our study, out of 263 patients with confirmed RT-PCR, 25 patients had ocular symptoms with conjunctival congestion, foreign body, burning sensation, watering discharge, and lid swelling. The mean age in our study was 38.8 years. Among them, a total of 99 had upper respiratory tract symptoms. Asymptomatic were 164. And 46 had systematic illness like diabetes, hypertension, hyperlipidemia, CVS disorders, chronic kidney disease, liver diseases, and cardiovascular diseases. And 25 patients had ocular symptoms. So this is the bar diagram and various symptoms, manifestations, what we have found in our studies, being conjunctival congestion being the most common symptom. Then followed by discharge, then watering and lid swelling. 68% people had conjunctival conjunctival congestion. So coming to discussion, most of the initial studies conducted during the emergence of COVID-19, the prevalence of conjunctivitis on COVID-19 patient ranged from 0.82% to 4.76%. The main observations from our study are only 9.5% of the patient had ocular symptoms in COVID-19 positive patients. The most common ocular symptom among the 25 patients was conjunctival congestion. There are very few studies published on ocular symptoms of COVID-19. Our results are in accordance with study conducted by China. Therefore, it is quite evident that conjunctival congestion could be an early and most common manifestation in COVID-19 patients. Coming to conclusion, mild conjunctivitis manifesting as conjunctival congestion is one of the major ocular manifestation in COVID-19 patients. Hence, we believe an ophthalmologist should become an important team worker in management of COVID-19 patients. One should have a high suspicion of COVID-19 in all ophthalmic patients presenting with conjunctival congestion. Therefore, necessary precautions should be taken when handling such patients. Detailed history and investigations to be done. These are my references. Thank you. Hello.
Yeah, Dr. Sana, you have given mainly the symptoms and also the findings, that is mainly anterior segment findings in
Yes,
these
ma'am.
patients. What about fundus examination using indirect? Was it done on any patients?
No, ma'am, we have not done. Basically, we have we have studied the ocular symptoms they are presenting with COVID-19 patients. What common symptoms they are complaining of.
Okay.
Dr. Sana?
Yes, ma'am.
I just have one query here. Yours was a study profile of COVID-19 manifestations. You have screened around more than 200 patients, if I'm not mistaken. 250 was the number.
Yes, ma'am.
Did you have any neurological manifestations, like any double vision or drooping of lid or any other?
No, ma'am. No. Nobody. They did had diminution of vision as such. No neurological, like visible neurological symptoms. We couldn't find, ma'am. But
All
yeah,
these patients-
I have done 2-3 patients like IDO. They were like suddenly complaining of diminution of vision. So we found some cotton wool spots since they had some DM associated with that. But yeah, ma'am, some patients were complaining of diminution of vision. But we couldn't do IDO because of this. We couldn't do, ma'am, because that was not our study part.
So most of these patients were ward patients. I come to understand that they were ward patients only that you had screened.
Yes, ma'am. Yes,
none
ma'am.
of the
Ward
ICU patients were screened. Okay.
No, ma'am. They were not. They were mild to moderate only.
Okay. Thank you.
Thank you, ma'am.
So what was the cause of diminution of vision in those patients then?
Maybe they had already associated symptoms like DM. They already had like
So it was not
associated.
attributable. It was not attributable to COVID-19 per se.
No, ma'am, I don't think so, because it was not very great loss. They did had previously. Since I introduced myself as ophthalmologist, they were complaining the diminution of vision at that moment, maybe, ma'am.
All right. Okay.
Thank you, Sana.
Thank you, ma'am.
Dr. Saida Zeba, are you there?
Yes, ma'am.
Okay, you can start presenting. Sana, you need to stop sharing your screen.
Yeah, ma'am.
The other person will not be able to.
Yeah, ma'am.
Good afternoon, everyone. Am I audible?
Yes, you are. Can you put it to PowerPoint show?
Yes, ma'am. Yes, ma'am. Today, I am presenting a paper on to evaluate the effect of COVID-19 pandemic and national lockdown on the patient care at tertiary care center in North Karnataka. The coronavirus infection spread throughout the country, leading to the World Health Organization declaring it as a global pandemic. In an effort to restrict the spread of this disease, many governments across the world enforced the lockdown of varying degrees in India. As per government directive, all non-emergency outpatient departments across the hospital and clinics in India were shut. All elective surgeries to be deferred and only emergency healthcare services to function. The ophthalmology, being a branch of medicine which largely deals with elective surgery, was significantly affected. The purpose of this is to evaluate the effect of COVID-19 pandemic and national lockdown on patient care at tertiary care in the North Karnataka. Methods. This retrospective study was conducted at tertiary care center dedicated ophthalmic hospital in Karnataka without an associated multi-speciality hospital. This hospital not only caters to the various districts within the state, but also to the surrounding states of Telangana and Maharashtra. Records of all the patients taking treatment at the institute from March 25 to 3rd May 2020 were evaluated with the help of electronic medical record. The electronic medical record of this patient who presented to the center during this lockdown period were scanned and relative data regarding their presenting complaints, final diagnosis, treatment, and advised and surgical intervention. We graded the patient as non-emergency or emergency based on the triage provided by AIOS. We also tried to understand if a detailed in-person examination was needed for evaluation of these patients or video consultation was sufficient. We also made a note of the cases where there an unprecedented delay in the undergoing the advised intervention caused by difficulties directly related to the lockdown. Results: the total number of OPT visits during this period were on the contrary, the total number of OPT visits during the corresponding period last year was 3,000. Thus, the OPT volume decreased by 96.6%. All the elective surgeries were postponed during the lockdown period. The emergency intervention was advised for 8 patients of whom had an imminent risk of visual loss. Around 80% could be triaged as a non-emergency. Many patients was for a video consultation. 2 patients presented with perforated corneal ulcer but could not undergo penetrating keratoplasty due to lack of available donor corneal tissue. 2 patients with open globe injury were referred to higher center. Around 9% patients could not undergo the advised urgent procedure. There has been a significant increase in lens-induced glaucoma from 2 to 4 as compared to the corresponding period of last year. And this shows the number of cases before the pandemic and number of cases during the pandemic. Cataract case were 50 before the pandemic and only 5 during the pandemic. Mature cataract cases were 10 before the pandemic and 3 during the pandemic. Lens-induced glaucoma was 2 before pandemic, and after pandemic it was 4. Refractive errors were 1,500 before the pandemic and 30 during the pandemic. Dry eye were 500 before the pandemic and 26 during the pandemic. Trauma cases were 50 before the pandemic and 3 cases during the pandemic. Conjunctivitis cases were 100 before the pandemic and only 10 cases during the pandemic. The number of STI cases were 30 before the pandemic and 11 cases during the pandemic. Miscellaneous 758 cases before pandemic and only 8 cases during the pandemic. A total of 3,000 cases were seen before the pandemic and only 100 cases during the pandemic. The T value is 1.8. The P value is 0.038. The result is significant when it is less than 0.05. Discussion. With the announcement of lockdown, our hospital also gave out the official notification in all the regional dialysis requesting the patient to visit the hospital only in case of an ocular emergency. The public showed a good compliance to the lockdown guidelines, and OPD load in our hospital decreased to a nearly 96.6% of its load during the corresponding time previous year. The reduced OPD and surgical volume not only posed a major financial challenge for the institution, but also increased the chance of high-risk patient not receiving an adequate treatment. The most common indication for surgery at our center during the lockdown were open globe injury and lens-related glaucoma. Penetrating keratoplasty could not be done due to unavailability of the donor corneal tissue. Eye banking has faced a major setback during the pandemic due to confusion regarding guidelines related to tissue harvesting. The number of patients could not undergo an urgent procedure, logistical and financial issues directly related to the lockdown. Conclusion. A significant number of patients could not get adequate treatment during the lockdown period. These patients need to be encouraged to follow up via video consultation to carve adequate inpatient time for the high-risk patients. Financial support and sponsorship was nil. Conflicts of interest, there are no conflicts of interest. Thank you.
Dr. Ziba,
Yes, ma'am.
you said that around 100 patients were seen during that period. Out of this, how many were review cases and how many were new registrations? Any data was collected regarding this?
No, ma'am.
And you said that about 26 patients were diagnosed with dry eye. How did you make the diagnosis? Did you do all the tests for these patients? Because it was during the first wave, right? Your study, which
yes.
So how was the diagnosis made? And you said that your trauma were 3, right?
Yes, ma'am.
But you said 2 were referred outside. What happened?
The open globe injury was there, ma'am. So they have been referred to higher center, ma'am.
Okay. And what were the miscellaneous conditions? 8?
Dry eye like that, ma'am.
Because dry eye is already given as a separate entity, right?
Yes, ma'am.
Yeah. Okay. That's it from my side.
Okay.
I have no more questions too. I guess we can go to the next one. Yes, please, Dr. Lakshmi.
Yeah, thank you. Good evening. Today, I'll be presenting a paper on study on self-medications in ophthalmic emergencies of South Indian rural population under the guidance of Dr. Sarita. So like we know, use of self-medication is a common practice in rural population. It can have a negative impact on our visual outcome. This can unfortunately be attributed to a malfunctional healthcare system with poor accessibility of quality eye care facilities. The practices related to self-treatment has not been extensively worked up yet. So this study would is hence planned to understand the practices of rural Indian population to determine the frequency of occurrence and characteristics of self-medication through a population-based survey. So the main aim of my study here is to determine the type and nature of traditional eye medicine or TEM and abuse of over-the-counter drugs, their sources, practices related to self-medication for all the emergencies in rural South Indian population, and also to determine their after effects and the irrational use of eye drops. It's a cross-sectional descriptive study, population-based, in randomly selected clusters of villages of Kerala and Karnataka. Sample size of 100 patients above the age of 18 years, presenting with ophthalmic emergencies who have had self-medication prior to seeking medical attention in our hospital, with a self-structured questionnaire was used. Study setting was in ophthalmology department of Fatmullah Medical College, Mangalore. Physical verification of drugs were conducted. Informed consent was taken from the patient, and also descriptive statistics is computed along with multivariable logistic regression analysis to determine associated factors for the use of self-medication. So we included patients above the age of 18 years who have used drugs for ophthalmic emergencies and self-medications prior to seeking medical attention in our hospital, and excluded population less than 18 years of age. So it was a questionnaire-based study regarding the use of self-medication. The questionnaire included name, age, gender, education qualification, occupation, type and duration of illness, history regarding the type of medication employed, knowledge about those drugs and possible side effects, and also factors influencing the self-medication. After effects of the drugs has also been analyzed on slit lamp examination when the patient presented to us. Later, the results were analyzed using descriptive analysis of the sample. So coming to the data, out of 100 patients that we screened, 53% were females, 47% were males, with a mean age of 50 years of age. Among them, 55% were illiterate, 35% had below primary level education, and 10% had above primary level education. Among the patients who have used self-medication, 37% of them used it for excessive watering, 28% for pain, 12% for redness and discharge, 14% for foreign body sensation in the eye, 5% for diminished vision and burning, and 4% for trauma. Various drugs instilled. Highest was 24% used antibiotic eye drops, 23% of them used expired bottles, 20% of them were chronically using steroid eye drops, 12% of them herbal or indigenous drugs, and 7% of them used NSAIDs, 15% used the traditional eye medicines. Of the home remedies, more than 45% of patients used kajal as a home remedy, and almost around 18% of patients used synth oil, and around 20% of patients used honey as a home remedy, and less than 10% used ghee. So when asked about the barriers for not using ophthalmic services, less than 40% of patients, around 38% of patients had distance to a nearby health facility as an excuse. And 25% of patients had objection by the family members due to COVID pandemic situation to reach to a hospital. And 18% of patients had gone to local healers, could be quacks as well, for their ophthalmic services. 10% of patients had financial constraints, and 8% of patients did not consider irritation or their ocular complaints as a priority to visit a nearby health facility. The outcomes, 30% of them presented with infectious keratitis, 25% had epithelial defects, 28% of patients had conjunctivitis, and 17% of the patients who were using chronic steroid eye drops presented with glaucoma. The limitations of my study, indeed, the population were given, the priority was given to older participants. My study was based on mean age of 50 years of age. So increased prevalence of the same in the population could be as a result of higher proportion of older patients. And also for a holistic picture, the study should have been conducted among urban population as well. Irrational use of drugs and traditional eye medicine can have dangerous visual outcomes. Education of the rural crowd and establishing quality eye care facilities can help us curb this scenario. To conclude, this study highlights the need of effective execution and establishment of high quality, accessible primary eye care services and healthcare referral network in rural India. So in order to reverse this trend and decrease the use of self-medication and its consequences, we need to strengthen our eye care programs, deliver promotive, preventive, and curative healthcare to underserved rural population. These are some of my references. Thanks.
Very interesting presentation.
Thank you.
Though I wanted to ask you,
yes,
what did you put in the box of traditional eye medicines?
Traditional eye medicines were the home remedies that patients were using. Most
right,
of them.
But okay, how did you differentiate them from those herbal remedies?
Herbal remedies were the ones which were prescribed to them by the quacks, and also the extracts from the plants they have already gotten, and they made bottles out of it and used regularly for their eye complaints. But these home other medications which were used include ghee, kajal, and like I've mentioned, synth oil, honey, and all of those things were included among their traditional eye medicines.
Okay. Also, what did you consider as an ophthalmic emergency? Because that's what your title says now. But does conjunctivitis come under that?
Yeah. So basically we have taken patients who have had ophthalmic emergencies, like sudden onset excessive redness and pain in the eye, discharge along with excessive watering, trauma, all of
Maybe
those
we
things
need
were
to
considered.
reconsider the terminology of ophthalmic emergencies, isn't it? Because
Yes.
it's not all the cases that you mentioned were actually emergencies in a sense.
Yes, ma'am. Not trauma-related emergencies. I mean,
No,
in
understandably so. There
Yes.
are a lot of others. So what are those other ophthalmic emergencies?
So the patients presented with sudden onset pain and redness in their eye could be epithelial defect that they've had. Also, I've included all of those things as well when I considered
Could the
ophthalmic
epithelial
emergency.
defect have occurred because of the home remedy?
Yes.
Or
Yes, so a lot of
So
patients.
how do we know whether or not that's the case?
Yeah, that one differentiating factor we had asked the patients when they came for follow-ups to us. We have asked if if the redness and excessive watering have started after they applied the eye drops. Most of them had said yes. They have had a minimal redness or burning sensation in the eye, for which most of the patients said they have used this thing called a synth oil on their face, and then after applying the medication, the burning sensation, photophobia has increased, and then they presented to us. So but we consider that as an ophthalmic emergency as well. That could be a limitation, but we had considered the excessive watering redness as an ophthalmic emergency as well.
All right, thank you.
Okay.
No questions from my side.
Okay. Thank you. Thank you.
Hello, ma'am. This is Dr. Suman Devamani. Can I start presenting, ma'am?
Yeah, if you're ready with your presentation, the final presentation, then I think you can start.
Yes, ma'am. Okay. So good afternoon, everyone. I am Dr. Suman Devamani, second year postgraduate studying at Adi Chinchukar Institute of Medical Sciences, Bellore. I am doing a paper under the guidance of Dr. Pooja HV. And here I am to present a paper on effects of high myopia on macular thickness and OCT-based study. Myopia is defined as a state of refraction in which parallel rays of light coming from infinity are brought to focus in front of the retina with accommodation at rest. Histopathological studies reveal that there is increasing scleral and retinal thinning with myopia. The optical coherence tomography introduced by Huang et al. It is one of the most widely used equipment to assess the fovea, peripapillary nerve fiber layer, and macular region for various retinal diseases. The modern imaging techniques have made it possible to evaluate the relationship between myopia and retinal thickness. Our aim was to study the effects of high myopia on macular thickness using optical coherence tomography. The study period varied between September 2020 to 2021, a period of 1 year in the Department of Ophthalmology at Adi Chinchukar Institute of Medical Sciences. All the patients visiting the outpatient department, more than 5-year-olds, 5-year-old were included in the study and were categorized into 20 emetropic eyes and 20 high myopic eyes. And all the diseases like macular scars, macular edema, and macular dystrophies were excluded from our study. This is a hospital-based observation study. The patients have gone through best-corrected visual acuity using Snellen's chart, anterior segment examination, intraocular pressure, fundus examination with indirect ophthalmoscope, axial length measurement using A-scan, and finally the measurement of macular thickness using optical coherence tomography. The circle that we see over here, these are the zones with which we have represented our various results. The inner one represents the center fovea. The next circle, which represents the inner macula, is the parafoveal, and the outer ring, which is 6 mm outer macula, is the perifoveal zone. Next, coming to the results, 40 people were enrolled in the study. The age of the patient ranged from 10 to 55 years, and around 22 males and 18 females were enrolled in the study. They were categorized into 20 emetropic and 20 high myopic eyes. The mean axial length was 28.18 plus or minus 1.17 mm. So from the table 2, we can infer that the macular thickness in superior, temporal, inferior zones was significantly thinned out in group 1 when compared to the group 2, which was statistically significant. And the inference from table 3 is that the macular thickness in all the zones was significantly thinned out in group 1 when compared to the group 2, which was statistically significant. The retinal thinning and chorioretinal atrophy are seen in histological findings and clinical observations associated more commonly with myopia, while the myopia correlated with macular thickness is found insignificant in vivo imaging studies. In our study, statistically significant thinning is seen in all the zones of perifoveal area of high myopia and in superior, temporal, and inferior zones in the parafoveal area, while the nasal zone of parafoveal area thickening was seen when compared to Zhao et al., where all the zones of perifoveal and parafoveal thinning was noted. This is similar to the study proposed by Vakitani et al., wherein the peripheral retina is thinner in the myopic eyes rather than the central retina, and Lim et al. And Liu et al., which also had similar results, stating that thinning in myopia occurred more frequently in peripheral part. Also, we found that there is statistical significance central foveal thickness, which was high when compared to emetropic eyes. These findings are similar to the study conducted by Samuel et al., which concluded that the foveal thickness in high myopes, which was significantly greater than the moderate and mild myopes. On contrary, a study by Lam et al. Proposed that perifoveal macular thickness reduced in myopia, but not the paraphobia. To conclude, the analysis of macular thickness in the evaluation of macular diseases or glaucoma should be considered based on refractive errors and the location of measurement. The introduction of OCT has made it easier for us to evaluate and diagnose the macular diseases associated with the refractive errors at a much earlier stage and to prevent the progression of the disease. These are the various references, and I thank all the COSCON members to give me this opportunity today to present this paper. Thank you, ma'am.
Did you categorize the myopes?
Yes, ma'am. Yes, ma'am. We had categorized into mild, moderate, and previous. Since my study was just focusing on high myopes, so I've categorized it into -6 to -12. That is high myopia, ma'am. Mild myopia was below -4 diopters, and -4 to -6 diopters. We had categorized it as moderate myopia, ma'am.
Dr. Suman, was there any difference in the macular thickness depending on the degree of myopia? Was it more thinner in higher myopes when compared to moderate?
Yes, ma'am. There's significant thinning seen in high myopes when compared to the moderate myopes.
What is the variation? Do you have any statistical analysis of the same? Because mild myopes, and most of them were axial only, I suppose, what you were taking. Were they all axial myopes? Were they all axial myopes?
Yes, ma'am. Not necessarily. Everybody was included with axial myopes, ma'am. And most
myopias were taken.
Yes, ma'am.
Did you just take myopias, or you concentrated only on the axial myopes?
I took general myopia, ma'am. Like as in all the myopes which came into the category of -6 to -12 diopters. I have included all of them in the study, ma'am.
Thank you.
Okay, thank you, ma'am.
So what is the implication of the study? How do they use it in clinical practice?
Yes, ma'am. Can you pardon me, please? I did not hear you, ma'am.
What is the implication of this study?
What is the implication, ma'am? Excuse me, ma'am. I couldn't hear you. Can you please? Okay. So basically, we wanted to. Yes, ma'am. Hello.
Please go ahead.
Hello, ma'am. Okay. The inference from our study was to know the various retinal nomograms associated with the high myopia, and also to know, also to prevent the myopia, like also to prevent any retinal diseases that that could lead due to myopia. Like we see various posterior staphylomas and all due to progressive thinning. To prevent that, we have done this study, ma'am.
Okay, thank you.
Okay, thank you, ma'am.
Yeah, thank you, Dr. Suman.
Yes, ma'am. Thank you, ma'am.
Dr. Purnima, are you there?
Yes, ma'am, I'm there, ma'am. I'll share the screen. Um, Good evening, everyone. Myself, Dr. Purnima. The topic of my today's paper presentation is a 5-year retrospective analysis of microbiological surveillance of ophthalmology operation theaters. One second. Sorry for the interruption. Coming to introduction, microbiological contamination of surfaces and environment in the OTs are the major risk factor for the surgical site and other post-op infections. The factors on which the rate of post-op infection depend are the effective sterilization, disinfection procedures, surgical techniques, theater designs, bacterial contamination of the air, OT staff discipline, appropriate use of prophylactic antibiotics. The present study was conducted to identify microbial colonization of surface and equipments of the ophthalmology OT of a district hospital. Objectives of the study are to identify the bacterial contamination of the surface and equipments in two ophthalmology OTs and to describe the seasonal variation in microbiological surveillance report and to correlate the microbiological surveillance report with the OT sterilization protocol. The materials and methods, 5 years, that is from May 2014 to 2019, retrospective analysis of the data was obtained from the routine microbiological surveillance. The study type was retrospective study and it was done for about 3 months. Methodology, microbiological surveillance reports of ophthalmology OTs was collected from our record section from May 2014 to 2019, and reports were studied for the total number of samples collected from the various surfaces, equipments, and the number of various bacteria isolated, and the predominant bacteria isolated from the samples were studied. According to the record, sampling procedure used in the study was surface swabbing. Sterile gloves, masks, sterile gown, caps were worn for the collection to prevent the contamination of media and the OT surface being swabbed. The surface samples were taken after proper sterilization and disinfection of the OTs. Sterile swabs were useful for the sample collection from different sites and equipments like microscope 1, 2, OT table 1 and 2, trolley 1 and 2, ACs and OT lights, floor, wall, and from the OT and swabs were taken once a month. Swabs collected were labeled properly and transported immediately to the microbiology lab for culture. If more than 3 isolates were isolated, repeat swabs were sent after proper sterilization of the OT. And the results were out of 739 samples from surfaces and equipments, 203, that is 27.46% yielded isolates. And the samples collected from the various surfaces like microscope 1 is 10.5%, 5%, microscope 2 10.5%, and AC 9.4, OT light 9.4, floor is 10.14, wall is 9.7, table 1 is 9.8, table 2 10.4, trolley 10.4, trolley 2 9.8.
And this is the result of the predominant species isolated. The predominant species isolated was Bacillus, that is, it was seen 30%. Staph aureus is the second predominant species isolated. The third was Enterococcus, and next was Klebsiella. And surface contamination, floor was the most contaminated surface, followed by microscope 1 and 2. And season-wise result is for the isolates were yielded more in the month of March. Result summary: out of 739 samples from surface equipments, 203 samples are isolates, and the predominant was Bacillus, that is in 98, followed by the Staph aureus. And floor showed highest isolates, and more isolates were found in March. And isolates were identified with auto protocols being followed. 739 surface swabs were collected from the OTs of the hospital with the bacterial contamination rate of 27.46%, which is moderate compared to the other studies, where positive rate ranged from 14.7% to 100%. A total of 9 different species were identified, and Bacillus species was considered to be an environmental contaminant of predominant isolate. Second was Staph aureus, which is commensal organism, and it's a potential pathogen and an important cause of soft tissue infections. This is in concordance with the other studies from India and abroad. Floor was the most contaminated surface, and microscopes were highly contaminated equipments, mainly because it's highly touched, and more organisms were found in month of March. This can be because of the atmospheric bacterial concentration is directly affected by the temperature. Coming to conclusion, predominant organism was Bacillus. Floor was the most contaminated surface. Seasonal variation was more in March. There was no correlation found with the OT sterilization protocol. Thank you.
Dr. Purnima, it's just one question.
Yes, ma'am.
You said that the period was for 5 years, right?
Yes, ma'am.
The duration of your study, the study was taken for a 5-year duration, right? Retrospective analysis. Yeah. In each year, did you find that in the month of March, there was more increase in the?
No, ma'am. Not in all the years. But compared to all 5 years, it was more in March.
Okay.
Dr. Purnima, you were talking about the floor being contaminated maximum in all these 5 years. Hello?
Yes, ma'am. Yes, ma'am.
Yeah. Any particular reason? Any analysis was done why it was just the floor that was contaminated all the time? Any analysis was done on that? Any measures were taken? Because every year you had floor being contaminated maximum. Yes. Any measures were taken to contain that, because this is over 5 years?
Yes, ma'am. Like sterilization was again it was done, ma'am.
The protocol of sterilization was done, OT sterilization, because whenever you do a study, it is with the aim of trying to rectify something, because over 5 years you had similar complaints. So,
yes, ma'am.
And another thing is, what about the air contaminant? Was air analyzed? OT air?
No, ma'am. In this study, we didn't analyze the air contamination. We didn't get the previous.
Because with all the OTs being air conditioned and all that, recently we had an episode of air being contaminated, and so many colony counts were seen, which was out of acceptable limits in our hospital. So that's the reason I asked. Even OT air has to be analyzed.
Yes, ma'am. Yes, ma'am. Actually, now
that's a very important part, especially in OT, which is air conditioned.
Yes, ma'am. Actually, as it was retrospective and 5 years back, we took the reports. The reports were not there about the air sterilization, so we didn't get the sufficient report, ma'am. That's why we didn't include that.
Okay. Thank you. Thank you for the presentation.
Okay, thank you.
Nothing from my side.
Dr. Ruchi? Dr. Ruchi?
Hello?
Yeah. Is your
Yeah, yeah, ma'am.
you can present?
Yes. Good afternoon, everyone. Is it audible, ma'am?
Yeah, you're audible.
Hello?
Yeah, you're
Presentation
audible.
is...
You make it
Yes, yes, ma'am. Is it shared, ma'am?
we can see the screen, but it is not in PowerPoint show. If you're not able to, then I think you can continue with it.
Okay. Good afternoon, everyone. My topic for paper presentation is a study of prevalence of vitamin A deficiency in school children aged 5 to 15 years in Ballari city. Introduction. As vitamin A deficiency is a major concern, especially for the children in the developing countries. And as such, children in the school-going age group belong to 6 to 16 years, represent 25% of the population in the developing countries. So it's one of the major concern for which can lead to which can lead to blindness. The materials and methods which are used in my study are the study design. It's a cross-sectional study with 700 school-going children between the age group 5 to 15 years. The study period was from November 2019 to January 2020. The inclusion criteria for my study was children of age group 5 to 15 years. And the exclusion criteria, the students who were having corneal scars because of trauma, any kind of congenital anomalies, and the children who were absent on the day of screening. The ophthalmic evaluation was done with the help of the diffuse torsion at the hospital.
Dr. Ruchi?
Then, hello?
Yeah, now we are audible.
Hello?
Yeah.
Yes, ma'am. The analysis and the results, it was seen that out of 700 students, there were 60% of male students and 40% of the female students. The distribution of vitamin A deficiency in the population. It was observed that the nil ocular signs of vitamin A were seen in 96%, and whereas the students who were having ocular signs were only 4%. Gender-based distribution of vitamin A deficiency was done, which showed females constituted to have major signs of vitamin A deficiency, that is 68% as compared to males, that is 32%. The ocular findings when doing my study, it was seen that only conjunctival cirrhosis and white spots were seen. Out of which the 17 students, that is 58.6% of these students had conjunctival cirrhosis, and only 12 students, that is 41.3%, had white spots. The distribution of vitamin A deficiency by age. It was seen that in the students belonging to the age group 13 to 15 years had manifested more amount of vitamin A deficiency, that is 51.7%, followed by 9 to 12 years, that is 31%, and 5 to 8 years, that is 17.2%. On comparing my study with Rahul Roy et al. Study, which was conducted in Ahmedabad, and Nareshti Chauhan et al. Study conducted in Haryana, it was seen that students, 5.7% of the students were having positive findings, whereas in Nareshti et al. Studies were 2.9. In my study, it was 4.1. The most common gender which was affected was female, and the most common age group which was affected was around 9 to 12 years. 9 to 12 years. The conclusion of the study is that with the prevention, early recognition, and prompt treatment of vitamin A deficiency with the help of regular screening of the students and nutritional education in the school would definitely decrease the risk of the ocular abnormalities. So the quality of the life, so the quality of the eyesight of the students can be improved. And for that reason, schools are one of the best centers for effective implementation of comprehensive eye healthcare program. Thank you.
This study done in the school as a part of school screening, or was it done in the base hospital?
As a part of school screening.
Okay. Were you able to get any relevant history from the children?
No,
particularly the
actually,
the higher age group?
History, like for example, nyctalopia and all, the students are not able to appreciate because it was not that severe. Only conjunctival, it was like more of an objective screening rather than a subjective one.
How was the diagnosis made?
With the help of the WHO classification, that the 1982 WHO classification. So students, maximum students came under X1A and X1B.
That is based on your science, no? You said that 23 children had vitamin A deficiency, right?
Yes, ma'am.
But ocular signs were seen only in 4. One chart where they said
yes, ma'am. Ma'am, 4% of the students were having out of 700. That is only 29% of the students were having vitamin A deficiency. And out of this 29, 17 students were having conjunctival cirrhosis and 12 were having white spots.
Okay. That's it from my side.
Nothing from my side.
If there are no more questions, I think we can move on to the next presenter. Dr. Salman. Thank you, Dr. Ruchi. Dr. Salman, are you there?
Yes, ma'am. I'm here. Hello?
Yes, you're audible. But,
yes, ma'am. Am I audible?
Yes, yes.
I'm sharing my screen now. Good afternoon, everybody. Today I'll be presenting a paper on clinical features and outcomes of COVID-19 associated mucormycosis. My chief author is Dr. Sangmeshwarya Salimat. Am I audible, ma'am?
Yeah, you're audible.
Yes. Rhino-orbitocerebral mucormycosis is a lethal opportunistic infection caused by molds belonging to the order Mucorales, most commonly Rhizopus species. A recent spike has been observed in the number of mucormycosis cases with the ongoing COVID-19 pandemic, and the mortality is high as 50% even after treatment. It has been observed that patients with COVID-19 are at an increased risk of acute cardiac injury, arrhythmia, thromboembolic complications like pulmonary embolism and acute stroke, and secondary infections, to name a few. Methodology. Ethical clearance was obtained from the Institute's Ethics Committee. In this study, 12 cases with rhino-orbitocerebral mucormycosis were presented after purposive sampling was done. After collecting the socio-demographic data of the patient, detailed history will be taken regarding the presenting complaints, paying special emphasis on COVID-19 symptoms, signs and symptoms of rhino-orbitocerebral mucormycosis. Duration of hospital stay, requirement of oxygen support, administration of steroids, pre-existing systemic comorbidities like diabetes, or hypertension. History of immunosuppressive medication like systemic steroids or immunosuppressives was also taken. Local examination was done, which included examination of the anterior segment of the eye with slit lamp whenever possible, dilated fundoscopy examination with direct and indirect ophthalmoscopy, testing of visual acuity, extraocular movement, intraocular pressure measurement using non-contact thermometer. Results of my studies were headache. Number of patients who presented with headache was 6, which accounted for 50% of the patients. Nasal discharge was seen in 2 patients, which accounted for 16.6% of the patients. Facial swelling and pain was seen in 7 patients, which accounted for a good 58.3% of the patients. A diminution of vision in 4 patients, eye pain and swelling in 3 patients. Black crusts on the soft palate and nasal mucosa was seen in 1 patient. Pre-existing comorbidities in my patients were diabetes mellitus was seen in 11 patients, that accounted for 91.6%, hypertension in 2 patients, use of steroids in 11 patients, the use of remdesivir during the treatment for COVID-19 infection was there in 8 patients, and oxygen requirement during treatment for COVID-19 infection was there in 10 patients. Investigation. Histopathological examination and fungal smear. Number of patients who were diagnosed on this basis were 11, and radiological evidence was seen in 8 patients. Discussion. A total of 12 cases of rhino-orbitocerebral mucormycosis were included in this case series. Common presentation was facial swelling and pain, followed by headache. 11% of which had pre-existing comorbidities like type 2 diabetes mellitus, and 2 patients had systemic hypertension. 1 case belonged to pediatric age group of 9 years old, male patient. 11 patients had a history of use of high-dose corticosteroids for treatment during COVID-19 infection, and 10 patients required oxygen support during COVID-19 infection treatment. In our study, the most common presentation of mucormycosis was facial swelling and pain, followed by headache. In our study, pre-existing comorbidities like type 2 diabetes mellitus and use of high-dose corticosteroids for managing COVID-19 infection was found to be a major risk factor associated with rhino-orbitocerebral mucormycosis, which is in concordance with various studies. In a case report published by Mehta et al., where they have reported a case of post-COVID-19 rhino-orbital mucormycosis, in which the patient received steroids according to the protocols after which he developed mucormycosis. Similar observations have been reported by Amanda et al. From America and by Chowdhury et al. From Delhi. Conclusion. Comorbidities like diabetes mellitus, hypertension, and immunosuppressed states, like due to the use of corticosteroids, has a role to play in causation of this lethal opportunistic infection. The treating clinicians need to be aware of the possibility of mucormycosis in such patients. These are my references.
Hello.
Hello.
Nice presentation. I wanted to ask whether you found any, what was the association between oxygen therapy you mentioned, right? Have other studies corroborated this?
Ma'am, there have been studies wherein they have corroborated the association between COVID-19 infection treatment, and they were using supplemental oxygen.
What is the reason? Any reason that has been mentioned?
Ma'am, use of the water which is used in the humidifiers, they have implicated usage of tap water or unclean water or unsterile water basically in those humidifiers, and their relationship with the causation of COVID, this mucormycosis in these patients.
Right. How long after the COVID infection did these people develop mucor?
Ma'am, in our hospital, 200 beds were allocated for the care of COVID patients, and a good out of 12 patients, around 6 patients, they were from these wards, and bedside examination was done for these patients, and the rest of the patients presented to our OPD. Usually, after 2 to 3 weeks after discharge from the hospital for treatment of COVID-19 infection.
Okay, thank you.
Thank you, ma'am.
Thank you, Dr. Salman. No questions from my side.
Thank you, ma'am.
Dr. Siddharth?
Yes, ma'am. Are my slides visible, ma'am?
Yeah, you have, can you go to the title?
Yes.
Yeah, put it in the PowerPoint show. Yeah. It's visible. You can go ahead.
My topic for today's paper presentation is a study of ocular complications in patients undergoing chemoradiation for head and neck cancers. My chief author is Dr. Rajesh R. Nayak. Coming to the introduction, head and neck cancers are one of the most common malignancies worldwide. In India itself, they account for 30 to 40% of all cancer cases. For the treatment, usually a combination of chemotherapy and radiation is given, which is known as concurrent chemotherapy. The commonly used chemotherapeutic agents are cisplatin, carboplatin, cetuximab, and gefitinib. Cisplatin and carboplatin are heavy metal platinum compounds. Cetuximab is a monoclonal antibody against epidermal
discharge and lid swelling.
And gefitinib is a tyrosine kinase inhibitor, which is also an EGFR inhibitor. The common complications usually seen with radiotherapy include medrosis, erythema, dry eye, watering, pigmentation, cataract, and punctal stenosis. The complications of chemotherapeutic drugs usually include non-specific blurring of vision, papilledema, optic neuritis, retrobulbar neuritis, blepharitis, and conjunctivitis. Coming to the aim of the study, the aim is to find all the ocular complications occurring in these patients who are about to undergo chemoradiation for head and neck cancers. Methodology: this is a prospective study with the inclusion criteria being patients with only cancer of the head and neck and patients who are about to undergo combined chemoradiation rather than just plain chemotherapy. Exclusion criteria includes patients undergoing chemoradiation for any cancer other than cancer of the head and neck. All the patients with head and neck cancer undergoing chemoradiation underwent the following examination: visual acuity, color vision testing, external eye examination, anterior segment examination using slit lamp, Sherman's test, and a dilated fundus examination. Coming to the results, 21 patients with head and neck cancers who are undergoing chemoradiation were taken up for the study. This included 16 males and 5 female patients. Out of them, only 3 were in the 20 to 39 year age group and 7 were in the 60 to 79 year age group, with the majority of 11 patients being in the 40 to 59 year age group. Coming to the types of cancer, the most common type of cancer seen was carcinoma of the buccal mucosa, followed by carcinoma of the tongue. Carcinoma of the hypopharynx and oropharynx was seen in 3 patients each, and carcinoma of the tonsillar fossa was seen in 2 patients. The chemotherapeutic drug used along with radiation can be seen here. Carboplatin was given to 8 patients. Cisplatin was given to 10 patients. Cetuximab was given to 1 patient, and gefitinib was given to 2 patients. The most common feature seen was dry eye, which can be seen here. In patients receiving cisplatin and radiotherapy, 4 patients had dry eye, which was done by Sherman's test. They had moderate dry eye. And 4 patients in patients using carboplatin also had dry eye. Medrosis was the next most common finding, seen in 3 patients with radiotherapy and carboplatin and 2 patients with cisplatin and radiotherapy. You can see the most common feature being dry eye, seen in around 38.1% of the cases, and medrosis seen in 23.8% of the cases. Blepharitis was seen in 1 patient, and conjunctival congestion was noted in 2 patients receiving radiation and cisplatin. 1 patient receiving cisplatin and radiation developed lower lid ectropion and lacrimation. 2 patients received gefitinib and radiation, out of which 1 patient developed trichiasis. This trichiasis led to recurrent corneal epithelial erosions. Discussion. Out of the 21 patients taken for the study so far, 12 patients, which was around 57.1%, had ocular manifestations. Dry eye was the most common finding, occurring in 8 patients. Medrosis was the second most common finding in 5 patients. Other complications seen were blepharitis, tracheasis, ectropion, and congestion. Ocular toxicity induced by anti-cancer chemotherapy and radiotherapy is not uncommon, but usually underestimated and underreported. Development of more aggressive agents and newer agents has seen an increase in reported cases of chemotherapy and radiotherapy-induced ocular side effects. These side effects are generally not preventable, and despite improvements in delivery mechanisms and protective shielding used for the patients, multiple complications are observed. So, early detection and dose reduction or discontinuation of a particular drug or the radiation may help in reducing severity and the duration of these side effects. These are my references. Thank you.
Well presented, Dr. Siddharth. Did you take the history from the patients between, what was the duration between the examination and their onset of the chemo radiation therapy?
Yes, ma'am. We had taken the patients who were admitted, ma'am. After they had been admitted, they were given chemo radiation for a period of 7 weeks, ma'am. They stayed in the hospital itself. So we took the initial findings before they started and findings at the end of chemo radiation. However, for 2 patients, the one who developed ectropion and one who died trichiasis, they referred to us because patient had severe complaints. So they referred to us at the 5th week, ma'am.
Okay. And you have not seen any posterior segment complications related to chemo?
Yes, ma'am. As of now, we haven't seen, ma'am. We have called for a follow-up after 6 months to look for any radiation retinopathy if that is seen.
And other than the trichiasis causing the corneal, you said manifestation, no other corneal manifestation was seen in these patients?
No, ma'am. But the
keratitis?
No, ma'am. No, nothing else was seen, ma'am. Only the recurrent corneal erosion, the erosions were seen. Patient had severe photophobia and pain.
Dr. Siddharth.
Yes, ma'am.
Dr. Siddharth, you said dry eye is the commonest complication. I mean, you have seen in these patients who are undergoing chemoradiation. What tests have you done to assess the dry eye on these patients?
We did Shermer's and TBUT, ma'am.
Shermer's and TBUT. And did you get to grade the severity, because you said they were inpatients and over 4 weeks you've assessed them?
Yes, ma'am. All of them had moderate, ma'am. None of them had severe dry eye, ma'am.
Okay. Did you treat them, or was it like what kind of treatment did you advise? I mean,
we had advised tear substitutes only for dry eye. For the patient with the ectropion, we had advised surgery, but they had refused because already very debilitating condition, so they refused.
Patients were assessed before the treatment. It was just after treatment that you have assessed for dry eye here, isn't it?
Yes, ma'am. Before starting and at the end of chemo radiation.
Before and after you have compared, is it? After chemo radiation, before and after?
Yes, ma'am. Before starting, we had checked the patient once, and after finishing, after a period of 7 weeks, we had checked the patients again.
So there was significant difference in the tear film.
Yes, ma'am.
I think if there are no more questions, we can end the session. I think almost all of them have finished their presentation.
Thank you. We're through with all the papers, right?
I think we are through with all the papers.
Okay. Thank you, ma'am. It was nice judging the session. Thank you.
Thank you for the opportunity.
Thank you.